I think Elizabeth's out of town, but that's just a few of the many people he's mentored over many years.
Well, thank you. That's really, really kind. Today, what I want to talk about is the blood-brain barrier as a therapeutic target. Over about 45 years, I've been giving talks on the blood-brain barrier, and I've, in retrospect, noticed that there's been a progression in themes in those talks. Originally, I started out mostly in my work and my talks talking about the physiology of the blood-brain barrier, its roles in nourishing the brain, protecting the CNS, aiding in brain-body communication, and acting as an interface between the CNS and peripheral tissues. But as time progressed, I increasingly discussed discoveries relating to diseases in which the blood-brain barrier was dysfunctional, and the therapeutic need to get drugs across the blood-brain barrier to the 6 cells of the brain. Nearly every disease in the CNS now is thought to have some dysfunction or multiple dysfunctions of the blood-brain barrier. And also there's a therapeutic need to get drugs across the brain. In some cases, the blood-brain barrier is the target of the disease, causing the brain dysfunction. And in other cases, the blood-brain barrier itself is actually the origin of the disease process. So it's clear that blood-brain barrier dysfunction is a major issue in disease states. That's well appreciated in the literature. But what hasn't yet taken shape, the part of the field that is yet to coalesce, is the concept that blood-brain barrier dysfunctions can be treated, and they should be treated, and the blood-brain barrier, particularly the brain endothelial cell, should now be considered a legitimate therapeutic target by therapeutic industry. I want to emphasize, though, that this lecture, although it's a blood-brain barrier therapeutic lecture, is not about getting drugs across the blood-brain barrier. That's a very well defined and very active field. What I want to talk about is targeting the blood-brain barrier itself. And a sign of how neglected this part of the field is that there are only 8 clinical trials that directly target dysfunctions of the blood-brain barrier. This compares to over 800 clinical trials for getting drugs across the blood-brain barrier in Alzheimer's alone. So if you want to read more about this field, I recommend the paper that just came out that Peter Sørensen and I just published in Nature Reviews Drug Discovery. Also, there's another paper from Britta Engelhardt's group in Switzerland that is very similar thematically. And then the third paper you see, The Penetration of Therapeutics, is sort of the paper that we wrote a couple of years ago and I presented at my last lecture that sort of is foundational to this concept and this approach. So one of the toughest things I found about starting a talk is where to begin, because you want to give the background, but the background often arose from something tangential, and so you wind up, how far down the road do you go? So after a lot of rumination, I decided to start today's talk about the fashion statements of the medieval European peasant. And this is a short part, because there was essentially no choice. Everyone ran around with brown or white or whatever the natural colors of the material that they had were. And the reason for this is because it was very, very expensive to dye your clothes. You had to really be upper crust. But interestingly, about 1700s, there was a fashion statement shift away from the royal purple that had been so popular in classical times towards dark blues, and the favorite was indigo blue. Indigo was a plant that didn't like to live in Europe. In fact, it did not. It lived far away around countries of the equator. It required a lot of work for extraction, fermentation, packaging, and shipping. This was an international enterprise, and it made people a pot of money. And so it was right to find cheaper ways to do this. Finally, about 1704, 1705, the debate's a little bit debated. A guy named Johann Jakob Diesberg figured out how to chemically produce a deep blue dye that we typically call Prussian blue, sometimes called Berlin or Parisian blue. He gets a lot of credit for discovering it, but really what he did is he figured out how to do this cheaply and reproducibly. And this was sort of the first crest of a practical result of chemistry coming out of the older alchemy. And in fact, this discovery sort of pushed that forward, that while you really couldn't produce gold from alchemy, you could produce a type of gold, or certainly wealth, from chemistry. And so he did this, and it became very popular. And it was first used in paintings, and still is to this day. Some very famous paintings have used this color to produce this great deep blue. And this is one of my favorites, ukiyo-e from Hokusai, called the Great Wave of Kanagawa. I think this is the most famous ukiyo-e woodblock print in Japanese history, about 1830, and it's really cool. But there are lots and lots and lots of other ones. And the adage was that it cost per gram or ounce or whatever about 1/10 the price and went 10 times as far. So 100-fold drop already. Eventually, it was used to dye textiles and wallpaper and eventually clothes. And in short, this made the German chemical industry a pot of money. This was one of perhaps the first technical industry that was just filthy rich because of the advancements. So what do industries do when they have pots and pots of money? They want to make more money, of course. And how do they do that? And there are three recurring themes, really. And one is to branch out. You know, if one computer worked, let's make lots of little computers and laptops and cell phones and everything else. And that's what they did. They made more and more colors. You can reduce production costs. They did that. They figured out ways to make all these dyes cheaper and more stable. And finally, you branch out to other fields. And the field that first came of great appeal was medicinal aspects. It's probable that indigo had some indigo and indigo blue itself had some low-grade medicinal effects. It's never really quite clear, but maybe some antioxidant effects, things like that. So as medicine arose and the idea that we could produce medicines rather than extract them from plants, a young man named Paul Ehrlich showed up on the scene at just the right time. Ehrlich won I think was the 4th Nobel Prize. He was considered the father of both the pharmaceutical industry and the field of pharmacology. And of course, he's very famous, and I think we all heard about him in med school because he created the magic bullet, compound 664, for the treatment of syphilis. But what that really represented was we can make medicines that cure diseases. And he was very interested in injecting dyes and see where they went. And I think this is because he was formulating the idea of site of action. In other words, if you want to treat a lung disease, your drug probably needs to go to the lung. Or the kidney disease, you probably need to go to the kidney. Not true in all cases, but site of action is a very powerful concept. Remember, into the 19th century, we don't have very good analytical methods like we do now. You can't take a tissue and extract from it what you want to measure and use HPLC or mass spec to do that. One of the few things he could do was to inject dyes with some medicinal aspect and see where they go. And so he was doing this with a new dye called Evans Blue, and recapitulate the story here. And sorry for those of you who have heard my lectures before, the next 5 or 6 slides you have seen ad infinitum, but I think they're a quick way to demonstrate the principles of the blood-brain barrier that we will need later in the lecture with regards to treatment, targeting blood-brain barrier. So here we've injected some Evans Blue, or trypan blue, either one is been used for this, into mice, and you see that they're all blue, and all the organs inside are blue, blue, blue. So blue they're almost black, that indigo black. At any rate, here's the brain, and the brain, as you see, didn't stain. Here's the skull, the inside of the skull. This is literally a millimeter away, and you can see it's bright, bright blue, even though there's not much tissue to stain. So originally, Ehrlich interpreted this wrong. He thought, well, the brain just cannot bind dye, because he had experience with this, that some tissues would have the chemical signature to bind something and others would not. But about 1920 or so, one of his students finally injected dye directly into the brain and it stayed just fine. So that gave rise to the idea of a barrier between the blood and the brain, given various names, and finally about 1930s blood-brain barrier. There was a man named Hugh Dafson that was critical to this story in two ways. First, he's the Dafson-Danieli, or the Dafson of the Dafson-Danieli model of membrane. I know that I studied that back in not grade school, but I think as an undergrad in biology. And this has also been called the Sandwich membrane, a bilipid membrane, which became fundamental to all of cell biology, not just blood-brain barrier. And then he did experiments showing that physiological experiments that the blood-brain barrier likely resided at the level of the capillary. So first, let's talk about his bilipid model. That is that there's a double layer of phospholipids facing out, and so this produces a very non-charged lipid matrix. And substances that are lipid soluble cross this membrane easily. If you're a steroid hormone, you're across this baby, no problem, equilibrium established and everything. If you're a water-soluble molecule, a very water-soluble molecule, this is really itself just a barrier. You're unable to cross because you have charges and you've got to stick into the water, which complements your charge and that kind of thing. And so a lot of cell biology was explained by this. To show you how universal it is, one of the first demonstrations of how vital this was actually in algae, blue-green algae. And what we're doing is just looking at the ability of a whole host of drugs and substances to be taken up by the algae. And you can see that the more lipid soluble you are, the more that you're taken up. There's also an effect of molecular weight. Smaller lipid soluble molecules cross cell membranes better than do large water soluble ones. This has been fundamental in drug development. And up until the last maybe 5 or 10 years, you could probably say that 98% of drugs that we use in clinic that are directed towards an effect in brain are small lipid-soluble molecules that cross by transmembrane diffusion. Just now, we're entering the area of peptides and regulatory proteins and large antibodies. So that field is finally shifting, but for 100 years, this is how you made drugs if you wanted to be successful. And morphine, ethanol, and nicotine are drugs of examples that readily cross the blood-brain barrier this way. Then there was a snag. This is about 1960s. Sort of the backlash, which always occurs in science as it does elsewhere. And people said, wait a second, Dafson's experiments are physiology. Physiology, if you're not a physiologist, is a flawed science. If you're a physiologist, it's premier science. But they didn't believe it because they say, look, we look at the blood vessels of the brain anatomically at gross level. There's no difference. It looks just like every other blood vessel. If you look at it in a microscope, it looks just like every other vessel. Where is the anatomical basis of the blood-brain barrier? And so people began rejecting this idea and going back to other ideas of tissue binding or pharmacokinetics in blood or things like that. And then finally, in 1967, a guy named Thomas Rees, who I got to read more about. I think this guy was really interesting. He was into electron microscopy, and I think he was a marine biologist. At any rate, he got into his head to look at the capillary bed of the brain by EM. And when he did that, he found the missing link here, the anatomical basis. Over here, we've got the liver, which is probably the leakiest capillary bed known to man. And you see that as you go through the cell, the very membrane, the cell itself is just punched out with holes, connecting the blood and the liver interstitial fluid. And here, these look like windows, cathedral windows, and they are indeed called fenestrae from the Latin word for window, fenestrae. And here are big holes, and this represents various vesicular systems they're very active. When we come to the blood-brain barrier, and then wherever the two cells come together, say another liver endothelial cell, there's big gaps between the cells, and just things are just leaking all over the place. But in blood-brain barrier, where a cell comes upon itself or another cell, they're cemented together by tight junctions. So there's no leakage between cells. And also, the fenestrae are all gone, and the various vesicular systems are greatly reduced. They're about 7% of what they are in any other cell. And that's probably the 7% that's highly regulated, not the leakage part. You can see one right here, the little vesicle, but otherwise things are not there. So now we had the anatomical basis of the blood-brain barrier, and work picked up again, and William Oldendorf, who was at the VA in, I think it was Los Angeles, went back and he looked again at this idea of lipid solubility and blood-brain barrier penetration. You can see that it works quite well. It explained a very fundamental thing, that you can take morphine, a very water-soluble molecule, put a couple of acetyl groups on it, makes it very lipid-soluble, and now it gets into the brain like a shot, and that's what heroin is. As a side, William Oldendorf almost won the Nobel Prize, not for this, but because he's the guy that figured out the computer programming so that you could do multiple X-rays and collate them in a three-dimensional model or go back and forth. In other words, he sort of discovered MRI. He also discovered that not all molecules follow this idea of lipid solubility. Here's a whole bunch of molecules that get in faster. That was discovered to be sexual blood-to-brain, sexual transporters in the blood-to-brain direction. And this will become very fundamental in our talk of various treatments of the blood-brain barrier. And just a common substance that crosses the blood-brain barrier by transport system is caffeine. It uses the adenosine transporter, and boy, am I thankful for that. We later showed sort of a similar thing that Oldendorf showed a few years later, looking at the lipid solubility of small peptides crossing the blood-brain barrier. We found that lipid solubility was important. There was a subgroup of substances that crossed much more slowly, and it turns out that was a transporter as well, but in this case, in the brain-to-blood direction, an efflux system. And a few years after that, P-glycoprotein was found to occur in the blood-brain barrier. This is a brain-to-blood efflux system, but it's known to have so many ligands. It's amazing how many ligands this has. It's estimated that about 30% of the substances we use in our pharmacopoeia are substrates of PGP. If they're weak substrates like morphine, then they don't get in so well. They can get in enough to have an effect. And if they're very strong substrates, they don't get in at all. And this is a highly modulated system and explains a lot of not only which drugs get into the brain, but when we have problems, like why are seizures all of a sudden with the repeated seizures, so you become resistant to seizure drugs. And a lot of other pathology is explained by efflux systems. Finally, a new kid on the block, or rather a refurbished kid on the block, is you can cross the blood-brain barrier by virtue of charge. Now, you heard me say that water-soluble charged molecules don't cross well. That's true. But if you're really, really, really charged, like polylysines, you get in like a shot by a different mechanism called absorptive transcytosis. This was first illustrated by a guy named Broadwell in 1990s using wheat-germ agglutinin. But this has recently gotten a facelift because the glycocalyx, which is one area that May Reed is doing really pioneering work in the glycocalyx. This is the, I think, May, you taught me this could be called brain snot on the blood side of the blood-brain barrier, as opposed to the brain snot called the basement membrane on the brain side. At any rate, it's got charges, and it's probably controlling this and protecting the blood-brain barrier, and actually considered now the first level of barrier. At any rate, if you're charged in the right way, you can get across by this mechanism as well. So congratulations, you survived learning about 150 years of blood-brain barrier physiology and pathology. And just as a quick recap, you can get across the blood-brain barrier if all the stars are right by being lipid soluble and small. You can be kept out or efflux from the brain. by an efflux system. You can get in if you're the right kind of charge this way, transport systems, and finally, blood-brain barrier disruption occurs in many diseases and causes a big problem. So the blood-brain barrier has all these roles besides protecting the brain from the things that are circulating in the blood, in addition to the barrier property. It also is important in brain nutrition, homeostasis, and communication by letting selectively the right things across. With all this complexity, you can begin to see that things, when they go wrong, can cause problems for brain function. And things are almost anything that you could now sit back and imagine from what you've learned goes wrong sooner or later. So there's lots and lots of diseases, conditions in which the blood-brain barrier has an alternate function or dysfunction or just is outright broken. And that's what we want to explore now, the blood-brain barrier's role in various states, disease, and otherwise. So let's start with the classic one. I think I've shown you this one before, but it's really fundamental because it illustrates a lot of principles. And that is, how do we get fever? Well, this is how it works, that some neuroimmune agent, like interleukin-1 or lipopolysaccharide or LPS, is the coat from the gram-negative bacteria, and it will shoot off the immune system like nobody's brother. So these substances interact at receptors on the brain endothelial cell, interleukin-1 receptor for this substance, and LPS at the toll-like receptor 4. And when it does that, it increases the cyclooxygenase expression in the brain endothelial cell, which produces more prostaglandins, which are then released into the brain, into the fever centers, and this causes fever. So guess what? This can be treated by aspirin or salicylic acid. And so this is sort of a very old classic example of how the blood-brain barrier is producing a conditioned derivative to the brain that actually affects the whole body, and that we can, by treating at the level of the blood-brain barrier, we can alter the disease state. And actually, it's more complicated than this. Prostaglandin is the poster child, but pretty much the same thing is going on with thromboxane, monocyte adhesion, and also lipozene is stimulated, which is sort of an anti-fever sort of thing. So this is obviously ancient, though, although aspirin was produced in 1895 by Bayer Company. It's already old, but we've been using salicylic acid since time immemorial. So this is sort of the ancient ancestral example of treating a blood-brain barrier disease. But there's a lot of modern science here too, and I just want to pass by a couple of concepts that this clearly illustrates. Again, the blood-brain barrier is formed by brain endothelial cells. They're separate, they're latched together by tight junctions. And this means that substances on this side of the membrane do not get over to this side. These two membranes are very different in terms of proteins and receptors, and the two don't really intermingle. And so that means that unique things can happen on this side versus this side. So, for example, you could have a receptor here bind to something and stimulate a secretion by the blood-brain barrier, as it does in other cells, and it could be released. And if it's released on the luminal side, then it's just talking to the cells over here. But it can occur that the information comes on one side, but the secretion comes from the other. And in this case, we've created a brain-blood link, and it really a brain-body axis. And there's a lot of neuroimmune axes that are based on this, as well as other ways. So this is a way that the brain and the body can communicate. And when this fails, bad things happen. I want to talk about one more classic disease of blood-brain barrier disruption and how to treat it. Again, this is around, so it's not startling because we've been doing this and sort of not realizing it. And that's hypertensive emergencies, which are very high blood pressures that are causing target organ damage. And I want to point out that two of the damaged organs, classic organs, are the retina and the CNS, or the brain. Both of these are barrier tissues, and what's really happening is either there's disruption of the blood-retinal barrier or disruption of the blood-brain barrier. That's at the heart of the problems that hypertensive emergency causes. And of course, the treatment is just to reduce blood pressure, but I'll show you the blood-brain barrier is much more involved than just that. Here's a couple of MRI from a guy or a person who's having hypertension and encephalopathy. And you can see on the T2 weighted image, there's this increased uptake of gadolinium, so the blood-brain barrier is leaking. And over here in the proton density image, you can see that too. So blood-brain barrier leakage. And here's a classic view of the retina with its hemorrhages and exudates and all that kind of thing. The point is the blood vessels of the retina, the blood-retinal barrier is being disrupted here. And there's classic treatments for this. And two of these, nitroprusside and nitroglycerin, depend on the production of nitric oxide. And as we'll see later, that nitric oxide is one of the recurring mechanisms by which we treat and can treat dysfunctions of the blood-brain barrier. Sometimes nitric oxide is a good guy, like here. Sometimes it's a bad guy. It actually is underlying the unwanted change in blood-brain barrier function. But here's an early example of that. Recently, I mean, within the last 10 or 15 years, a big shift has gone to angiotensin II as being a major culprit in the vasculature, the vasoconstriction and the disruption of the blood-brain barrier. And here's the reason why. The brain endothelial cell expresses angiotensin I receptor. It doesn't express the AT2 receptor. Those are the two receptors for angiotensin. And we showed that angiotensin II opens the blood-brain barrier to albumin and also to TEER, two different measures of blood-brain barrier disruption. TEER says that there's a patent channel between one side of the blood-brain barrier and the other. That usually means the barrier, keeping the cells cemented, the tight junction has opened, and now electrons can go back and forth through that. That's TEER. And the bigger the TEER, the lower the TEER, rather, because when the barrier is intact, the TEER level is very high, which means there's a big resistance. And then when the blood-brain barrier opens, the more electrons go in and bigger molecules can go in, the TEER plummets. And the other one is albumin, which probably can get in through that way, but also gets in through other vesicular ways. And this can be blocked by telmisartan, an angiotensin I receptor antagonist, preventing blood-brain barrier disruption by angiotensin II. There's also another interesting story here. And if we look at TEER, after we put on angiotensin II, this is an in vitro study, you can see the TEER progressively gets worse and worse. Blood-brain barrier is opening more and more and more and more. But if we look at albumin, which is, of course, a big molecule, we see an immediate disruption and then a repair. It goes back to normal. This isn't statistically significant anymore. It's about the same as the baseline. So how can this happen? How can the blood-brain barrier open increasingly to one type of measure and yet open and close to another? And the answer goes back to what we learned from Reese, that there's different ways that we closed the blood-brain barrier. We closed the leakage between cells with tight junctions, and we closed the leakage across the cell by getting rid of fenestratin, greatly decreasing penocytosis. So the answer is probably angiotensin II is doing two things at once. It's opening the vesicles, the vesicular or transcytotic mechanisms, or transcellular mechanisms. But they recover, but the loss of tight junctions is more progressive and lasts longer. So, you know, I love history, so I got to just show you this, that the most famous patient with hypertensive encephalopathy, he had it forever, malignant hypertension, was President FDR. And he died from a stroke. This killed him. But here's his blood pressure as it went up over the course of his presidency. Of course, he was elected over here about 1932. And you see that eventually he hit systolics of close to 300 and diastolics of nearly 200. Interestingly, they seem to have gone down on D-Day, Election Day, and when he was in Yalta. So I wonder if after D-Day and election, although those are tense times that they occurred, and so he's under less stress. But as you see, they were very high. And of course, malignant hypertension has its cachexia, and it's interesting to speculate cachexia could have had a brain aspect to it, because a lot of cachectic syndromes begin in brain. And here he is at Tehran, very vigorous looking guy, 1943, and 15 months later, here he is at Yalta. You can see he's definitely cachectic, and he died 2 months after this. So a bit of history, perhaps due to, in part, deterioration of the blood-brain barrier. So I'm going to return now to inflammation. We talked already about fever, but when you get sick, a lot of things happen, right? You know, you think of the last time you had COVID or the flu or something like that, and you know, you feel lazy, lethargy, you want to sleep all day, you don't have much interest in anything, you're kind of depressed in a way, lost appetite, irritable, you don't want to talk to people, you don't want to have sex, you don't want to take a bath, you don't care about the environment, you can't think very well. And this is really a syndrome, and it was pointed out by Dancer and Keith Kelly that this is really an adaptive syndrome, that this is a way that when you're sick, your body removes the use of energy by all of these things, because social interaction, all these other things, thinking and all that, they take a lot of energy, a lot of calories. So you rest and you use all that energy to fight off the disease. That's the theory, is an adaptive change in motivational state that reorganizes priorities to cope with infection. Or as my grandma used to say, you rest so you can fight the disease. So, but my grandma was not offered co-authorship by Kelly or Dancer. But at any rate, so that's really what it is. And interestingly, all of these different aspects are mediated between the infectious signals in the blood and the response in the brain across the blood-brain barrier, but by different pathways. So we already talked about fever and how it's mediated by PGP and COX-1. And it turns out that there are changes in the HPA axis, stress axis, cortisol release, hypothalamic pituitary axis, by a very similar pathway. And it's also the beginning of the pathway that gets a lot more complicated and mediated specifically through the striatum that results in the malaise and discomfort. But what I want to talk about is the depression and how it's mediated by blood-brain barrier. And to do that, we got to first go back to William Oldendorff again and remind you that he found not only lipid-soluble things get across the blood-brain barrier, but there's also blood-to-brain transport systems. And when you have one of those, your ability to cross the blood-brain barrier can be perhaps 100 times greater than it would be otherwise. So, for example, phenylalanine is very water-soluble, you can see here, and yet its rate of crossing is very, very high. And that's because there's a blood-to-brain transport for large neutral amino acids called LAT1. And it transports the 9 large neutral amino acids, 9 of them. These are also essential amino acids. That means the body can't make them, and therefore neither can the brain. And a lot of these are very important to brain function. Well, they're all important to brain function. Some because they produce important neurotransmitters, like tryptophan produces serotonin, tyrosine, epinephrine, norepinephrine, dopamine. But they're also used for building blocks and all kinds of other things too. So this is a very important system. What's interesting is that all 9 of these cross by the same transporter, so they're competing with each other all the time. So if you have more leucine has a better chance of getting across than say isoleucine, because they're competing with each other. And this produces 2 diseases that I only want to mention in passing, phenylketonuria and maple syrup urine disease. The problem here is that phenylalanine for PKU is missing an enzyme that should degrade it. So phenylalanine levels are high. Therefore, it's blocking other things from getting in. Phenylalanine levels are high in the brain. That's bad because phenylalanine metabolic products are toxic. And it's also a problem because it's blocking the other amino acids getting in, so you have a deficiency of those. Same story for maple syrup urine disease, except it's the 3 branch chain amino acids that are causing the mischief, leucine, valine, and isoleucine. But that's not really the main story today. It is worth mentioning that by putting people in a diet that's high in the other amino acids, there's some ability to treat these, but mostly you have to have a diet that's low in the perpetrating amino acid. So the one I want to talk about is tryptophan and kynurenine and how it produces depression. So if you have an inflammation out in the periphery, particularly interferon gamma, stimulates IDO, an enzyme that converts tryptophan to kynurenine. And then kynurenine crosses the blood-brain barrier by the large neutral amino acid system. And there it's broken down to various products, eventually getting to quinolinic acid. So these two guys, particularly quinolinic acid, are very neurotoxic. There's also evidence that this is happening in the brain as well, tryptophan being converted to kynurenine. But the main source is thought to be, if kynurenine is thought to be from the periphery, overproduction by the inflammatory process. And these two are related to the depression. And I want to show you evidence for that. So from what I've told you before, you might come up with the idea, well, if they're all transported large neutral amino acid, maybe we can block kynurenine getting in by eating more or giving more large neutral acids to block them. And then the question becomes, which one would you use? You wouldn't want to use tyrosine, for example, because it's too fat soluble. You can't get enough into the bloodstream. It just doesn't work that well. So you need one that's water soluble. You go through the list. Leucine turns out to be a good candidate. So the question is, could leucine block this problem? So here we've given animals LPS, which we know will convert to more kynurenine, and here down here we measured in plasma and brain. We see, yep, more kynurenine in the brain and in the plasma when we gave kynurenine. And sure enough, they have the animals drink less sucrose, and they have decreased swimming mobility. These are 2 measures of depression. These are rats and mice. I think these are rats. They love to drink sugar water. So if you ever take a rat out to the bar, they won't drink the alcohol. They'll drink the sugar water. They just love it. And when they don't, it means they're not interested in life anymore. If you're not interested in sugar water, you're not interested in life. And also in mobility is swimming, is they're so depressed, they're not even trying to save their lives by getting out of the water. And leucine reverses both of these. If you give leucine peripherally, it reduces both of these. And sure enough, it also blocks leucine getting into the brain. So it all kind of fits together. And then we can give kynurenine directly into the bloodstream. And sure enough, it goes up very high in the brain if we do that. And we block it with leucine. If we give kynurenine, yes, they get depressed. They stop swimming. We give kynurenine plus leucine, yep, they start swimming again. So, and then while we were doing this work, we made another kind of interesting discovery that kynurenine is transported in by LAT1. We knew that already. But it's also transported out of the brain by another transporter, not LAT1, an efflux transporter. And thank goodness this transporter does not transport leucine. So what we have here is inflammation increases the blood levels of kynurenine across the blood-brain barrier that then causes, through its various metabolites, depression. And it's also kynurenine is being effluxed out of the brain at the same time. We can block the entry with leucine, and although there's more leucine in the brain, it doesn't interfere with the efflux system. So we got really a nice model here, a nice way of doing this. And so this is one of the 8 clinical trials that's ongoing by Ibrahim Haroun and Emory University, treating patients with leucine to see if it helps their depression. There's lots of other diseases that have deficient transport systems, but none of these, except maybe leptin transport and obesity, have no treatments. So we're not going to talk about them. So I'm going to switch to disruption and talk about disruption in the blood-brain barrier. This is the best known part of the field of brain dysfunctions because it's the easiest to measure. It's the one that people think of when they think of the blood-brain barrier and tend to neglect the transporters and things like that. So as you see, there's lots and lots and lots of diseases that have disruption of the blood-brain barrier. And actually, this is a very small list. This list I chose because in most cases, there's a suggested treatment to counter the disruption. We need to talk a little bit about disruption itself, though. Remember back with the work of Reese that there's different ways to make the blood-brain barrier, then there's different ways to disrupt the blood-brain barrier. So the question arises, are there different treatments? If disruption of the blood-brain barrier isn't singly caused, will there be different treatments for the different disruptions? So that's a question we have to think about as we go forward in this. So, for example, here's traumatic brain injury. This was done by David Cook and Art Logston. And what they showed is that if you whack the animals, that within 15 minutes, they've got a disruption to sucrose, and it begins to recover gradually with 24 to 72 hours. If we measure disruption with albumin, however, we see that initial disruption, a total repair, and then an opening again. So we have once again, just as we saw previously with hypertensive encephalopathy, we have discordant changes, different blood-brain barrier disruption, yes, but different stories for different molecules. So this is partly explained by the same story that we invoked for hypertension, that there's the crossing between the cells, sucrose is smaller, and then there's this transcytotic or transcellular pathways that albumin can take advantage of more so than some of the other molecules. But we're also seeing another part of the story, which is people have long been suspicious of, that the blood-brain barrier after trauma or other event, particularly after trauma, can open and close, open and close. And this is thought because you've invoked neuroinflammation that doesn't go away. It's this battle between repair and restatement of the disease processes. And bizarre things kind of happen, as we'll see. In some cases, areas of the brain unaffected previously will open and other places will close. And this shows you how complicated that the various blood-brain barrier disruptions are. The tight junctions over here, this is how big a molecule, how much they open and how big of a molecule can get in. So the tight junctions are in blue here, and they only open somewhere between 5 and 20 nanometers, probably 10 is the max. So that's big enough for things like albumin, which is 7 nanometers to get in, but it's too small to let in viruses, red cells, white cells, any of those things. If the fenestrae that we talked about also come in various sizes and flavors, and they're kind of smaller over here. And really to get bigger things in, you have to re-invoke some of the various vesicular systems. They vary also in size. And so for example, you could open by the Clathrin vesicles, and that's big enough to get parvovirus in it, but not Zika, et cetera, et cetera. So here's an experiment done with traumatic blast injury by David Cook. And we see here's a blood vessel that he's looking at, and this colors the nanoparticles leaking out of the blasted vessel, nothing in the sham. And here's what he showed over time. Here's the sham vessels you see. Nothing gets in, so it's just cleared from blood over time. But here's at 45 minutes is this big leaky area of the blood-brain barrier. And with time, it begins to repair itself and to clear. But look here. Here's a new disruption. It wasn't here originally. And it gradually formed over time. So one area closed and another area opened. So this opening and reopening is reinstated here in a cyclic kind of way. And we see this not only within a given vessel, but we see this across regions. Here's an animal whose spinal cord has been lesioned down at the lumbar area. And you see that immediately after surgery, there's no disruption of the blood-brain barrier. But as time goes on, after about day 7, the spinal cord barrier opens, and it begins to recover. But it's distal, delayed in time. And then way over here in brain, some of the brain areas open up and close again. So there's probably is, again, neuroinflammation sort of raging through the system, a war between its control and not. And the take-home pay here is that we can treat this with COX-1 with a nitric oxide inhibitors. Told you we'd see nitric oxide again. In this case, nitric oxide is promoting the opening of the blast. And if we use L-NAMI, then we can open the, which inhibits nitric oxide production. We can prevent the opening. COX-1, our old friend in prostaglandins, doesn't really do much. It doesn't do anything statistically. And you may remember it was a champ at another point, but here it's not. So this does say that there's different ways of opening the blood-brain barrier in different disease processes, and there will need to be different treatments for those various processes. So here's inflammation again. This back our old friend with LPS, lipopolysaccharide. And it doesn't take much LPS to affect an animal. We've given here 0.03 milligrams per kilogram, a very small dose, and measured body weight. As you see, the animals begin to lose weight. And we give about 10 times that, they lose a lot of weight. So they're very sensitive. It's producing anorexia, sickness behavior in these animals. And so here it shows low doses will do this. But to disrupt the blood-brain barrier, we have to use really high doses of LPS. So this tells us something else about blood-brain barrier disruption, that it's not that easy to disrupt the blood-brain barrier. In fact, it's easier to affect all those other functions in the disease process, the transporters and the enzymes and the glycocalyx, than it is to affect the tight junctions. They're really resistant, really resilient. The other thing it shows is that even though we've given a huge amount of LPS, these animals have now lost 20% of their body weight in 24 hours. These are really sick guys, a huge cytokine storm almost. The disruption isn't large. There's a little bit of sucrose that gets in normally, and we've only gotten in about another 5 microliters worth of sucrose. Now, if this were the liver and we did this, the microliters per gram would be about, in the liver would be about 200 microliters per gram. So the blood-brain barrier is still giving up ground very slowly and very, very resistantly. And in this case, indomethacin will prevent the disruption caused by LPS. N-acetylcysteine, which is a play on oxidative stress, does not do anything. Won't have time to show you, but there are other diseases of blood-brain barrier disruption where things like N-acetylcysteine will prevent the disruption. And finally, the last example will be diabetes. There's blood-brain barrier disruption in diabetes, as there is in the retina. Of course, retinal disruption, retinal blood-brain barrier disruption is the most common cause of blindness in Western civilization induced by diabetes. Diabetic retinopathy, which is essentially disruption of blood-retinal barrier. Not all areas of the brain, however, have disruption in the blood-brain barriers here by the cerebellum. The cortex shows delayed disruption, and the midbrain shows early disruption, but only to small molecules like sucrose. And as time goes on, it becomes disrupted to larger and larger molecules like albumin and inulin. The disruption of the midbrain follows the disruption of the retina. So there's a similar process going on. And in fact, we know what that is. We know how the blood-brain barrier, blood-retinal barrier becomes disrupted in diabetes. Too much glucose in the blood means too much glucose in the brain interstitial fluid. The pericyte, which is the cell that tells the blood-brain, one of the cells that tells the blood-brain barrier to, the brain endothelial cell, the capillary bed, to become a barrier, takes up a lot of this glucose. It just uses all the glucose to produce more ATP. Its Krebs cycle is not regulated, and pericyte is not very good at dealing with oxidative stress. Every time you go through the Krebs cycle, besides ATP, you also create oxidative stress. So it kills the poor pericyte. When the pericyte dies, the blood-brain barrier and the blood-retinal barrier are open. So if we could stop the Krebs cycle, if we could throw the pericyte into Warburg metabolism or anaerobic glycolysis, we could probably save the parasite in the blood-brain barrier. And we can do that by giving mitochondrial carbonic anhydrase inhibitors, such as topiramate. So that's what we did. We treated animals with streptozotocin, made them diabetic, and 5 of the 10 areas of the brain had disrupted blood-brain barrier, and 3 of those areas, when we treated them with topiramate, had repair of the blood-brain barrier or were prevented from becoming disrupted. So again, we can do this, and there's clinical trials that have looked at topiramate mostly in blood-retinal barrier disruption, and I think the results are promising but mixed. It's been a while since a new study has come out. But so here's interesting area for further investigation. I'm going to skip the last one, which has to do with stroke in neonates. I think I showed it to you before. And I would love to take questions and hope that I've entertained you as much as confused you. But hope to let you know that maybe in 9, I mean, if I were around for another 5 or 10 years, I might be able to open a blood-brain barrier treatment clinic. But that's the state of the field. Thank you all very much.
Thanks so much, Bill. Anyone who has a question, please feel free to unmute. And if you cannot unmute, you can put it in the chat.
Someone else have a question? Oh, someone. Okay.
Okay. This is PJ from Cleveland, Greg.
Hi.
So, wonderful talk. Wonderful the work. I really learned a lot, and also associated stuff that I've been working and caring the patient. My specialty for in the clinical is for take care of patient with delirium, dementia. So I think this is this topic is relevant, and I have seen a lot of patients, for example, with the delirium, and when they have infections, and the literature has suggested that some of this is due to the brain the barrier disruption, as you explained in your the presentation. So I have a few questions. So one is for acute change. For people with the delirium, this is the acute change in the mental state. This is with multiple reasons. One of the reasons is the disruption of the BBB, and you mentioned about the brain blood barrier open close using the brain traumatic injury. But what about for the inflammation part? Does that also occur? This is open, close, the cycle in acute situation?
I don't know anyone has looked at that, but we do know that once you induce neuroinflammation, it tends not to go away. Even if the inflammation is induced peripherally and spreads to the brain, and the peripheral inflammation recovers, the brain is unforgiving in this way. It seems to be stuck in a neuroinflammatory pattern. And although it may progress in different ways in different aspects of it, but there's like always elevated cytokines of one kind or another for the longest time. So it's set up for that. I just don't know that anyone has gotten around to look at it. That would be a great next experiment.
Yes, and there's also some called the intervention use different the mechanism of drugs. Then I'm wondering, yes, so maybe there's some kind of the experiment as well as the clinical trial to see if the intervention can help to speed up recovery or preventing the occurrence of the delirium. So that will be something I'm really looking forward to see. And that's for acute part. And for chronic condition like dementia, and the inflammation has been associated to be studied, and reported to be associated with the development of the dementia, neurodegenerative disorders.
Yeah.
And so, do you have anything to elaborate kind of more about it? How this is the
Yeah,
work?
if I given a talk about diseases of the blood-brain barrier rather than treatments of those diseases, Alzheimer's in particular would have been a lot of time spent on that. It's been known for about 10 years that there's a very low level of blood-brain barrier disruption in the hippocampus and a few other areas, I think striatum. It's just at the level of detection for DCE MRI, but it is there. But there's other dysfunctions of the blood-brain barrier that are probably even more fundamental. So I talked about the efflux systems. Amyloid beta peptide is taken out of the brain by two transporters, PGP and LRP1, and both of those go offline completely in AD, not only in AD in humans, but in every animal model of Alzheimer's disease. PGP doesn't work, LRP1 doesn't work. And so the A beta is not effluxed. And it's thought that that's one of the major reasons that A beta accumulates more in brain and eventually leads to plaques. And a guy named Zlakovic has looked at this and shown that the earliest problem in the blood-brain barrier, in the Alzheimer's disease brain that has so far been detected has been a loss of the pericytes. The pericytes die about 10 years before you begin seeing A beta accumulation. And we know that the pericytes not only control the blood-brain barrier integrity, tell it not to become disrupted, but there's also evidence that it at least talks about LRP1 and tells it to speed up, slow down, and that kind of thing. So it may be that that where we need to start targeting, NIH is all into treating people sooner, and yet I'm sort of one of these people that not sure that you're ever going to fix AD by thinking about plaques. Maybe you can think about by fixing the blood-brain barrier and fixing the pericyte early on. So I think that's, for me, the most exciting part of the AD story right now.
Yes. Well, looking forward to have your next presentation update to this.
Thank you.
Yes, thank you so much. I really appreciate it.
Thank you.
So that's what you need to do in retirement. You need to make as many presentations as possible. Thank you for sharing with us, and we appreciate this capstone, but also all of the work that is yet to come. So thank you for sharing with us, and thanks for all that you do.
Thank you. Bye, everybody.
And Bill, next week is a colleague of Bill is going to do research conference, but it will also